Now, this is the history of a 12-year-old premorbidly normal child who's living in Dubai. She had coughed for 2 months, episodic dry type of cough, aggravated with exertion. There was exercise intolerance for 1 month, breathlessness and palpitation was there whenever she walked around. Even a little bit of walking was making her very breathless. There was no weight loss documented, and there was no fever ever in the last 2 months. The family history of respiratory allergy. The previous investigations done in Dubai, this was a chest X-ray which showed bilateral infiltrates. The CT chest was reported as diffuse reticulonodular micro-opacities in both lung fields. And a diagnosis of miliary tuberculosis was considered. The mantle was 6 millimeters in duration. ESR was 20. And empirical anti-tuberculosis treatment was started on 7/4/2018. She was not tolerating the entity. She had gastritis and mild transaminitis, but we continued for a month. Because the child was not feeling well, she was brought here. On examination, she was alert and active and afebrile. There was no pallor, icterus or cyanosis, no clubbing, lymphadenopathy or rash. BC scar was there. Vitals were all within normal limits. The saturation was 99% room. Height and weight were okay. She was a well-built, okay built child with a height in 25 to 50th percentile and a weight which is much more than required for her height. On examination, the work of breathing was normal. The test examination was absolutely good. There was air entry was equal bilaterally. There was no findings on the chest at all. The cardiovascular system and rest of the systems were all within normal limits. Peripheral smear was normal. ESR was just 25. CRP was less than 1. LFT was normal, and IgE was 1,667. The gastric aspirate, TB, CBNAT, and AFP smear done twice were negative. DNA immunofluorescence was positive, but mild pattern only. Double-stranded DNA, ANA profile were negative. So with this, I'd ask Dr. Somu Shivbalan to come in and tell us what the differential diagnosis for chronic cough. Dr. Somu Shivbalan, as we all know, is a consultant pediatric pulmonologist. He has the Afro-ADVAC Travel Scholarship, Johannesburg, South Africa, 2018. It's a visiting fellowship of the Royal College, RCPCH. Best Doctor Award by Tamil Nadu State Branch, MGR University, 2012. An active participation award of the IEP TNSC. Published 54 papers and 26 chapters in textbooks, and authored Essentials of Pediatric Pulmonology and United Airway Disease, National Executive Board member of the IEP twice, and Joint Secretary of the National IEP Respiratory Chapter twice. Financial Secretary of the IEP National Respiratory Chapter 27 for 2 years. He's very, very involved in the Respiratory Chapter. Over to you, Somu, for your presentation. Somu?
Thank you, sir. Thank you, IAP Cochin, for the opportunity. And here the main thing is the child is 8 years, right? Yeah. Child is 8 years. And the child has been having cough and also breathlessness and exercise intolerance also the child has. What happens is, most of the time when there is a cough, whether that is significant or not, that takes the central stage. And the remaining things get masked even when they complain, because even if the attenders come by, they will always keep saying cough, cough, cough. One cough, if they say 10 times, it becomes a chronic cough. So we have to differentiate between acute and a chronic cough. It is a persisting cough or a recurring cough, because depending on that, it goes by. Then mainly we have to see if it is a dry cough or a moist cough, meaning expectoration need not be there in very small children. So we call it dry or a moist cough. So here the pattern of presentation can be recurrent. If it is recurrent and when there are no other risk factors or red flags, then probably you can wait. If it is going to be progressive, then it is persistent and it is not coming down, or it is becoming progressive with days, then definitely it is a thing of concern. Even without any red flags, we have to evaluate on that. Some, like your URI also, with certain viruses and atypicals, that can take a longer time, somewhere around 2 to 3 weeks also it can take. but those are in a minority. Most of the time by 10 to 14 days, they get resolved. But when the child is otherwise fine, no risk factors, and overall things are in normal limits, then even in that time, you can wait and watch. So these are the things. Everything needs to have a end point. Beyond the point, what we call it as normal for 1 week, if it becomes 2 weeks, it is not that normal. If it is 3 weeks, it's definitely not normal. So, and also by the severity, we can't be waiting for 3 weeks when there is a significant cough to a life-threatening cough or life day-to-day activity disturbing cough. So these are the things to be had in mind. And after differentiating whether it is persisting or recurrent or slow resolving, then we have to see if it is an isolated cough. Isolated cough, here again, it is divided into two, whether it is acceptable or significant. That I'll talk to you about a bit later. Then is cough associated with other symptom, like URI or LRI symptoms, or other respiratory symptom, then other systems getting involved, like if the child has malabsorption or diarrhea or vomiting or skin lesions, any other systems are getting involved, then we need to see what are the red flags and risk factors which we'll be talking about. Next one, sir. So with regards to significant cough, there are no exact definition to call it as a significant cough. Certain definitions are for one particular scenario, not for all. So I would rather say, as a clinician, any cough since birth becomes significant. Any daily cough, even if it is mild, if it is beyond 4 weeks of time, then it becomes significant. And you can't wait for 4 weeks. Any cough which is beyond 2 weeks of a progressive nature, that becomes significant. Even if it is less than 2 weeks, if it is acute life-threatening event, if the child chokes and falls, you can't say it is only one episode. So it becomes a life-threatening event. And any cough which is disturbing your day-to-day activity, even if it is less than 2 weeks, to the extent of affecting your routine activity, eating and sleeping, then it is significant. Any cough with distress, hypoxia, chest pain or hemoptysis, you cannot choose to ignore. Even if it is for a day or two, it has to be taken significant. Any cough with persisting voice change or feeding and swallowing difficulty, then it should not be ignored, and always look for risk factors and red flags. The red flags are daily moist or productive cough, feeding with difficulty with choking or drooling, chest pain, chronic exertion, dyspnea, hemoptysis, persisting voice change, failure to thrive, that is important, and also loss of weight, that also becomes significant. Any auscultatory finding on the chest along with cough, it can be localized or diffuse, that is significant. That includes both your cardiovascular and also respiratory system. Any cough with digital clubbing cannot be ignored, and associated with hypoxia, more so when the hypoxia is not getting corrected with oxygen, then that is a thing of concern. When there is a cyanosis, you cannot choose to ignore. And the other risk factors are any children with orocraniofacial anomaly, like your Down syndrome or a syndromic child, Peary-Roberts sequence, they are more prone for upper airway obstructions. So in this scenario, they become a high-risk individual, and these things you cannot opt to. What you call it as a normal, in a normal child, a child with Downs, you have to give an extra eye and a ear to that particular child before we reassure them as normal. Any child with thoracoskeletal abnormality like kyphoscoliosis, ribcage anomaly, they all tend to have a lung restrictive pattern, so that is important. And neuromuscular or neurodevelopmental issue, they can have ineffective cough, and airway clearing is also a problem. They cannot, the muscles are not that great, and they will not have a augmenting effect in clearing the secretion, so we have to be careful on that. Any multi-system or chronic diseases, including a rheumatological problem and vasculitis, you have to. And of course, the immunodeficiency, we know the mnemonic spur, you have to apply that. With regards to the type of cough, I have told you what a significant cough is. There is an entity called a normal and an expected cough, meaning even a normal individual, if everybody's mic is on and if you keep listening, through the session, somebody or the other will be coughing. It doesn't mean they are having any problem. But what happens is, most of the time, when they keep a watch on whether the child is coughing, even 1 or 2 times coughing becomes significant. So it is up to us to make sure whether it is a normal variant or associated with problem. So the studies say 34 epicoccus of cough, meaning 34 times coughing, which is not disturbing the child or not having any risk factors or red flags, then probably you can call it as a normal. That happens to be the majority. Then there is something called the non-specific cough, meaning you don't have any particular clue on the clinical examination or the history. Most of the time it is after the URI or so, the cough receptor sensitivity persists for some time and it takes a longer time to come down. And the other thing is a specific cough, which is a minority, but most of the cough, anytime we tend to think of this entity alone, though it forms a minority, but this cannot be chosen to be ignored. And with regards to the cough, it can be either central or peripheral. Central can be anxiety and psychological. They also call the habit cough. Always ask the history of do they cough more at night. Don't ask that. Invariably you'll be bold and you'll be taken aback, because they say invariably the child coughs more at night, because when people are around they tend to cough more, and people are around most of the time, not during the day, more at the night. So we ask them whether the cough is there when they sleep or when they are awake. So that makes a real distinction. So they will cough right through the night till they go to sleep. After going to sleep, if they don't have a cough, then probably you know what it is. So that becomes a diagnosis of exclusion, but you have to be very clear on what you are eliciting on that, because you will not be by the side when the child is sleeping. And peripheral, it can be pulmonary or non-pulmonary. And when you talk about non-pulmonary, it is always important to know the distribution of the cough receptors. It's not only in your airways. It can be there in other than airways, like your gastrointestinal tract. It can be in the stomach, it can be in the lower esophagus, and it can be in the external auditory canal also, and parietal and visceral, and in the pleura it is there, and also in the pericardium it's there. So cardiovascular problem you can have, neurogenic irritation you can have, and gastrointestinal problem you can have, and also pulmonary problem you can have. And the cough receptors are not definitely there in epiglottis. So that we have to know. And lower down the airway, the intensity of the cough receptors comes down, and definitely it is not there in the alveolar and the parenchymal station. So more the cough, don't think about parenchymal involvement directly, but there is no condition called where it only affects the parenchyma and not in the airway. So that's why there will be always a mixture, and more the cough, think of airways, and more the distress, think of parenchyma. Otherwise, there are always exceptions to the rule. And the common causes are, most of the time, it is a post-infectious cough syndrome. It can be because of bacterial, though we think that to be the common cause. It is mostly because of viral infections and also atypical organisms and also pertussis. So all paroxysmal cough, think of pertussis or pertussoid cough. Pertussoid cough, the other viral and atypical component comes into play. Because of the distribution of the cough receptors, even a GERD. GERD, we always used to think as a postgraduate that what is in the stomach comes to the airway, falls into the airway, and causes a choke and cough. Because the receptors are there in the gastrium and also in the lower esophagus, even a trivial esophageal reflux, you can have a cough. And of course, in asthma, you can have a cough, but all coughs at night should not be equated to asthma. There is an entity called UACS, that is the upper airway cough syndrome. This is nothing but your postnasal drip. Any drip to the back of the nose, it not necessarily sinusitis alone. It can be because of allergic rhinitis, vasomotor rhinitis, and of course your sinusitis they can. And persistent moist cough, if it is a moist cough, then always think of persistent bacterial bronchitis. It is a forerunner to your bronchiectasis and chronic suppurative lung disease. Of course, your pertussis. And with regards to allergy, we always think about food and dust. We don't give much importance to the occupation and the environment where the child lives in. That also becomes an important thing with regards to history. The uncommon causes are, because of most of the time, the common causes we need to concentrate. But when things are not responding or behaving in the way they are expected to respond, then probably also look into and have it in the back of your mind the uncommon causes. It can be the anatomical problem like your airway or your cardiac problem, or it could be because of an aspiration syndrome. Aspiration syndrome, we all know foreign body. We also think of GER, but we don't think of something called the swallowing dysfunction or your palatopharyngeal dysfunction. So that also has to be had in mind. Of course, your communication, like your aerodigestive problem, like your TEF and the clefts also have to be had in mind. The hereditary problems like cystic fibrosis and primary ciliary dyskinesia can also cause chronic cough, and immunodeficiency because of secondary infection and your upper and lower respiratory getting involved, you can have. And the miscellaneous causes are ILD. ILD cough can be there, though not the predominant symptom. So and also even drugs, you have to have it in mind. Even irritation of your external auditory canal can cause otogenic cough.
So that's, thank you, Dr. Somu, for that. Now this is the X-rays of this child. One was on April 4th, and the other was on May 5th after coming to the hospital here from Dubai. April 4th, and we have the investigations were done earlier. I'd like Dr. Kabra to now explain those X-rays. Dr. Sushil Kabra, I don't think requires any introduction. He is a professor of pediatrics in All Institute of Medical Sciences, New Delhi. He's the editor-in-chief of the Indian Journal of Pediatrics, and his research interests are cystic fibrosis, asthma, tuberculosis diagnostics, and ARI. He's got 550 publications to his credit and chapters and 170 books. What more do you need from a person like, from a doyen of pediatric pulmonology? His books are Essential Pulmonology, Pediatric Pulmonology, AIMS PICU Protocol, Case-Based Review of Pediatric Pulmonology, and 10 more. Over to you, Dr. Kabra, for your first introduction to the X-ray in this child.
Thank you, Dr. Jason. Whenever we are seeing X-ray, we should be trying to read it systematically. So first and foremost is what is the exposure of this X-ray. So how do you check the exposure is that you see the all the vertebra and heart, and generally because heart starts from T2 onwards, and we should be able to see the vertebra through and through, but not so clearly that you are able to see the intervertebral disc. So generally above the T2 to T4, you may be able to see the intervertebral disc. After that, you are able to see the vertebra, but not the intervertebral disc. So exposure here is okay. Next. So it is normal exposure because you are able to see the vertebra till here, intervertebral disc. Position, then you check for the position by, in children, whether it is rotated. So one is you look for the clavicle. They are normal here. But in children, specifically younger infants and children, you will try to see whether it is a normally positioned by seeing the anterior end of the rib to the midline and the distance of the other side also. So it should be same in both the sides. Then you say that it is normal position. So here it is more or less normal, slightly rotated towards the left side. Then you look for the cardiophrenic, costophrenic angle. So this is cardiophrenic angle, this is costophrenic angle, they are within normal limit. And then you look for the lung parenchyma. Here you can see there are reticulonodular appearance, and all the lung fields more in the lower zones, lower parts. Then the upper part. Upper part you can see they are less dense or not able to see, but in the lower part you are able to see. So there is reticulonodular appearance or reticulonodular shadows. And in our country, commonly you will think of tuberculosis as one of the possibility, but it is not for TB, as you will be seeing it in the next few slides, that there are certain things which needs to be kept in mind, because you cannot say these are reticulonodular shadows and there are multiple causes for it. Next.
Okay, so this child had a X-ray which showed retinoidal shadows, and this is the PFT, that was the spirometry which was done on this child, and the FEC was 36%, the normal FE 1%, FE 1%. Small size loop with features of significant restriction was seen. I'd like Dr. Somo Balan to explain this spirometry and then go forward with explaining about spirometry in general. Dr. Somo, please unmute.
We will look into the specifics, but before that, when we look into a spirometry report, invariably we like to look into the interpretation, like how we see a ECG. So that is not the way.
Hello.
Am I audible?
Yeah, you're audible.
Yeah. Usually when we look into the spirometry report, we try to look into the interpretation part of what has been reported. So most of the time that's what happens. But ideal would be to doing it ourselves, or it is a lot of technicality that is involved, or at least know the person who is doing it. So if you are sure that he is doing it fine, it's okay. And always look into the time volume curve. and also the flow volume loop. That also gives you an idea whether it has been done properly, the way in which it is, whether the start is good, whether there has been hesitation, whether it has been done for a considerable period of time. That gives a rough idea. And the shape itself gives a rough idea of what it is, because restricted meaning you are restricting yourself, meaning you shrink yourself. So the shape is okay, but the size is low. So that is restriction. When regards to obstruction, there is the change in the shape of the curve. So that is obstruction for you. So now we look into the specifics. So usually the instrument is called the spirometry and the tracing is called the spirogram. Next one. Next one, please. So what it measures is volume of gas available for exchange, maximum inspiration and maximum expiration. What goes in and goes out is what is being measured, and it doesn't measure the residual volume. That's why we cannot calculate the total lung capacity. So it is more suggestive of obstructive diseases rather than restrictive diseases. It can give a suggestion of restrictive diseases, not confirmation of restrictive diseases, but for obstruction it is worthwhile. So here we don't look into the residual volume. That's why the functional residual capacity and the total lung capacity cannot be recorded. Whereas the vital capacity is your maximum inspiration to maximum expiration, where the tidal volume in between is your normal respiration, normal tidal respiration. So this measures predominantly the vital capacity or your FVC. Next one. So ideal, as I said earlier, is to interpret with your flow volume loop, volume time curve, and also the absolute values for flow and volume. So all these three has to be seen in conjunction, and then we have to make an interpretation of that. Next one. So we look into, though many parameters can be displayed there, but most of the time we try to look into the FEC, FEV1 and the ratio, that is the FEV1 by FEC, and also the force FEF 25 to 75%. MMR also we call it as. So these are the things we measure. There are slight changes in the values, reference values between pediatric and adult. Overall, for FEC and FEV1, it is 100 plus or minus 20. And with regards to the ratio, anything more than 80 is fine. Whereas for the very smaller airways, that is the FEF 25 to 75, it is 100 plus or minus 35%. With regards to obstruction, I told you the shape is altered, and here everything is less. Because of the obstruction, the function FEC is less, FEV1 is less. So naturally, the ratio also has to come down, and the smaller airways are also involved, and so FEF also can be low. With regards to restriction, it is the size that changes, but FEC and FE1 can be low, and it is low, but you'll be wondering, that side also it's low, this side also it's low, but how come the ratio has been maintained normal? Here, the FEC is more low than your FEV1, considerably. That becomes more low than your FEV1. That's why when the denominator becomes of a proportionate increase, then probably the net result also changes accordingly. So that's why your when the denominator is low, your numerator is not that low, then your ratio is more than 80%. That's why sometimes it can be normal also, sometimes it can be slightly of an increased value because of proportionate decrease, considerable decrease in your FEC. So these are the things we should have it in mind. And as I said, with regards to restriction, the same size shape, but the size is small. With regards to obstruction, the shape and size are altered. So with time, when you happen to see multiple tracings, you will know how it is. With regards to the upper one, with regards to the flow loop, upper one is the expiratory one, and the lower one is the inspiratory loop. And the expiratory one, if there is going to be concavity, more the concavity, it tells you more of obstruction. So that is one thing you have to see when you look into a loop. Please.
Please mute. Galaxy 12. Yeah.
Next slide, please. So intrathoracic obstruction and extrathoracic obstruction. Intrathoracic is anything above your below your collar button is your intrathoracic airway. Anything above your collar button, that's the neck and above, is your extrathoracic airway. So as I said earlier, expiratory part is your upper one. So the when there is going to be an extrathoracic obstruction, that is your upper airway getting obstructed, the lower loops are much affected. When there is an intrathoracic obstruction, your upper loop are more obstructed. So that one you have to have it in mind. Next one. So you will have a simple algorithm, and further details we will also be seeing in the quiz again. The algorithm, first look into FEV1 and FEC, the ratio. If it is normal, then you keep it aside. But when it is reduced, then it is of an obstructive defect. When it is normal, then go and check your FEC. And your FEC is also normal, then it is a normal spirogram. But when the FEV1 and FEC is normal and the FEC is reduced, then it is a restrictive defect. That tells you that FEC is more reduced than your FEV1. That's why the ratio has been maintained as normal. How to interrupt a PFT in general? Normal does not always rule out asthma. We think that it is only done for asthma. Supposing a well-controlled asthma who is asymptomatic at that particular point in time, who doesn't have a bronchial irritability or hyperresponsibility, that can give a normal value. So a normal bronchogram does not rule out a airway problem. That has to be had in mind. Then there are certain things of seeing how the bronchodilator responses. More than 12% increase after a bronchodilator, either in FEV1 or FEC, then probably that becomes a significant one. Or a trial of inhaled corticosteroids after 4 weeks, if FEV1 or FEC is increased by 12%, that again becomes significant of bronchospasm or airway inflammation. And bronchial hyperresponsiveness, we don't do the challenge test like methacholine challenge and all usually, but exercise-induced hyperresponsiveness we always tend to see. If the in older people they say 6-minute walk test. In children, whatever activity they can do as much as possible, we ask them to do. Then at 5, 10, and 30, 15 minutes and 30 minutes, we try to see a spirogram again. Most of the time, we do before the activity, then 5 minutes and 15 minutes after activity. This is what we generally do. Usually by around 10 to 15 minutes, the changes tend to happen, or sometimes even immediately within 5 minutes also sometimes they tend to happen. And if there is going to be a drop of 10 to 15%, then probably that becomes significant. And most of the reference values in the reports, the data which we see, are calculated reports based on standardization. And most of the time it is based on height, age, and ethnicity. And if you have a personal best in that particular child, it will be always worthwhile to compare with their personal best. Supposing they have a better value than what has been shown in that graph, then probably the next time when we sequentially do, we have to titrate, or we have to compare with the personal best, not with the machine added personal best. Sometimes that can lead on to lot of confusion. So here again, just to say, FEV1 by FEC ratio, as I said earlier, sometimes it can be normal or it can be increased also. So check the, after that, if it is normal or increased, check the FEC. If it is normal, it is a normal study. Click on it, sir. If it is low, then probably it is suggestive of restrictive lung disease. And with regards to the ratio, if the ratio is less, it is suggestive of obstructive lung disease. Here again, you check the FEC. If it is normal, then probably it is a pure obstruction. Then you try a bronchodilator response. If it is reversible, it is asthma. If it is not reversible, probably it is a COPD. And when in a low ratio, if FEC again is low, probably it could be suggestive of combined obstructive and restrictive disorder. With regards to children, what happens is the lung and airway keeps growing. with age, right from younger age to adolescent. They say the lung can grow up to 12 to maximum of 18 years. So 12 predominantly till 18 years it can grow. But as they grow, what happens is FPC keeps increasing more proportionately as compared to FEV1. That's why children tend to have a ratio which is much higher. They can even a normal thing, even in Guinea, they have two cutoffs. For younger children, it's they say more than 85, but for older children, they say 75 to 80%. So those are the trivial things which you have to know. But overall, remember that 80% as a cutoff. But because of this mechanism, the younger child, the ratio tends to be around 90%. As they reach adolescent, it becomes 80%. So that's a small thing which you have to know about. Even the mechanics of your chest wall and the alignment of your ribs and the muscles also plays an important role in the dynamic change of your FEC and FEV1. And initially when they grow, only the lower part of your body, that the lower segment grows more than the upper segment. In the adolescent spurt, the upper segment grows. That is the time you have a lot of changes in your FEC and FEV1 accordingly. That's why younger the child, the ratio tends to be more. Older the child, the ratio reaches an adult of around 80%. And here there is a thing called impulse oscillometry, or also they call it as impedance oscillometry. Here it is a equivalent of spirometry, but what happens here is it is a simple and non-invasive method of using force oscillation. We don't use it regularly, but when the company person gives us as a trial, we use it for some time. But here again, it can be done in younger children, even as young as 3 to 4 years, if they can coaxed and coached. But what happens is they again have to keep a mouthpiece in the mouth, and they have to have a normal tidal breathing with the nose blocked through the mouth. If they can do a normal tidal breathing, it doesn't have any forced expiratory or inspiratory maneuver in it, but a normal tidal breathing, the machine gives a lot of impedance resistance, and then in the form of impulse, and records the lung function accordingly. That is just I would rather say, I don't know whether Dr. Kabra will agree with it or not. It is though it is said to be simple, for younger children, they don't find it that simple also. And this is a surrogate of spirometry. It is like quantiferon gold for man too, I would rather call it as. It's a good experimental tool, and it will be coming a big way, though it has been used in only select centers for now. Kabra and his team has published data on that, and the conclusion what they have said is spirometry and IOS are comparable in ascertaining controlled asthma, and IOS, that is the impedance oscillometry, is less effort dependent and may be performed for monitoring control of childhood asthma, especially in younger children. So wherever spirometry is needed, IOS can also be done in a smaller child. Here again, though that much of cooperation and understanding is not needed, some amount of understanding and cooperation is definitely needed to be done. So it does not mean an infant or a less than a 2-year-old can do it. Only a slightly smaller children and not too small children can do IOS also. Thank you.
Thank you, Dr. Somu. So we had this child, 8-year-old child, who had a chronic cough, and tuberculosis was the diagnosis there with a because the CT had shown some starry night appearance, and therefore the child was started on antitubercular treatment for a month. All the ESR, the CBNAT, and everything was negative. Manto was only 6 millimeters, and therefore we repeated the CT to see and reviewed the old CT scan also. HRCT was reported as homogeneous and diffuse distribution of uniform size centriacinal nodules throughout the lung parenchyma. There was no associated findings of bronchiectasis, consolidation, lung fibrosis, consolidation, or pleural effusions. And the radiologist at our center, who's a very good pediatric radiologist, Dr. Ranjini, said that it's very unlikely to be tuberculosis. It is probably interstitial lung disease, mixed connectivity disorder. You must think of follicular infections or autoimmune mediated bronchiolitis, atypical or lymphocytic interstitial pneumonia, subacute case of hypersensitivity pneumonitis. So this was the differential that she gave, and she totally ruled out the possibility of tuberculosis in this child, saying that HRCT reviewed the old HRCT and the new one. And so on the third day after admission, the second day of admission, I think, once this HRCT was seen, we stopped the anti-tuberculosis treatment. Now this was something that we were worried about, but she was so convinced about it. And so I would like Dr. Meenu Singh to now come in and tell us why was miliary tuberculosis excluded after review of HRCT, and explain the role of HRCT, serology, and bronchoscopy for chronic cough. Dr. Meenu Singh is a professor of pediatrics. I'm sure all of you met her at the Bristlecon in Kerala. She's the professor of pediatrics at Advanced Pediatric Center and head of the pediatric pulmonology department in PGI Chandigarh. She's bestowed multiple awards, including the P. Bhaskar Raju Award, Senior Scientist ST HR Award, FCCP, American College of Chest Physicians, and FIAP. Got in significant contributions to research of asthma, tuberculosis, cystic fibrosis, and is currently working on an ICOM project on IBPA. Is the site director of South Indian Cochrane Network site at PGI Chandigarh and the steering committee member of the South Asian Cochrane Network and Center. I introduce you to Dr. Meenu Singh for her presentation.
Thank you, Dr. Jason, for this kind introduction, and good evening, everyone. As soon as a child with chronic cough comes, especially if it is in the older age group, like all other disorders with cough, people order radiological investigations first. They get a chest X-ray done. They get some blood investigations, and they also do MANTO to rule out tuberculosis if there is associated fever, weight loss, etc. But as is now, we've come to the stage when the chest CT has been done, and looking at the chest CT, an experienced radiologist has ruled out the possibility of tuberculosis. And as we know, the only other day we were discussing about tuberculosis, that there are certain things which are considered to be highly suggestive of TB, and miliary mottling on chest X-ray as well as on CT is one of them. But there is something like other things which we can say about a chest CT is that it is more precise than a chest X-ray. It sometimes is helpful in making specific diagnosis. For example, there are many conditions in which you would now get only a chest CT done, for example, to demonstrate bronchiectasis, or if there are lung abscess, or if there is a something like a hydrated cyst. These are very characteristic appearances on chest CT. It also acts as a site for lung biopsy, because lung biopsy is something which is done in cases of interstitial lung disease. And if it is not a diffuse lung disease, that means if the spread is not uniform, then one would go for the site which is most affected. So the common patterns which are seen in ILD is ground glass opacity. There might be hyperlucency seen if there are features of obstruction, for example, in bronchiolitis obliterans. Sometimes you get hyperlucencies in other conditions also, and asthma is one such very important obstructive disorder. There would be consolidations, which could be due to infections or other forms of inflammations like rheumatological disorders. There may be septal thickening, which can be seen in interstitial lung disease and thought to be characteristic of interstitial pneumonias. And there can be lung cysts and nodules, which can be seen in fungal infections. Lung cysts are seen congenitally being present there, or they could be acquired, as I alluded to earlier, like a hydrated cyst. So CT is also helpful in providing prognostic information, because the extent of the disease is estimated on a CT chest in diseases like cystic fibrosis, also in interstitial lung disease when extensive fibrosis has set in, or traction bronchiectasis is present. So these are some of the things which are very helpful when we do a chest CT in the patients. Now, when we compare the findings of HRCT in miliary tuberculosis versus other forms of interstitial lung disease, as you can see that here in miliary tuberculosis, the nodules which are usually are uniform size nodules, and their size is usually 2 to 3 millimeters, and they have a random kind of distribution. Whereas in diffuse lung disease, there is a ground glass opacity which is present, and there may be fibrosis which is seen, and there may be traction bronchiectasis. Now, one of the conditions is hypersensitivity pneumonitis, and I think specifically this is being discussed here because this child also had a high IgE levels, which were more than 1,000 international units. So there are some ill-defined nodules and ground glassing, which can be seen in hypersensitivity pneumonitis, which are marked with these yellow markers. There is a mosaic pattern and a ground glass opacity, which is seen, which could be patchy and present. There's certain lucencies which would be present. And the distribution here is centrilobular kind of a distribution. So this is how differentiation is done between miliary tuberculosis, between hypersensitivity pneumonitis, and a diffuse lung disease, and an experienced radiologist can actually do it very well. Now coming to the approach to an interstitial lung disease, which now that we have made up a little bit of our mind looking at the chest X-ray and the CT, that this child did have interstitial, there's a possibility of interstitial lung disease. The treatment for tuberculosis has already been stopped. So what are the other things which we do for in a patient with interstitial lung disease? After history and examination, we do pulmonary function test, the details of which have already been given by Dr. Somu, and they may tell us about the type of pulmonary involvement, whether there is obstruction or restriction, what has already been said, and certain diagnoses actually can be made on that basis. Then there are certain blood investigations. And in these blood investigations, we do mostly we first order a hemogram, and in a hemogram there may be anemia. If there has been a pulmonary bleed, for example, in idiopathic pulmonary hemosiderosis, there may be neutrophilia in inflammatory disorders or in infections. There may be lymphopenia in certain forms of immune deficiencies, especially in SCID, but that is seen in a much younger age population. And then there could be eosinophilia, which is suggestive of an allergic disorder. And in this child also, I think we would see whether there is eosinophilia present or not, because that can tell us about if there is any allergy to a parasite or to any other element, which could be antigenic. ESR is certainly elevated in patients of tuberculosis, and that can help us in making that diagnosis. There are other tests also which can be done on the sputum, and sputum, as we know, that can tell us about pulmonary bleed if there is hemosiderin-laden macrophages which are present in the sputum, but that is also would be seen in case of bronchoalveolar lavage. Now in HRCT, which is then done after a chest X-ray, usually one may see ground glass opacity in the parenchymal lesions. There may be peribronchial vascular changes or air trapping, which may be present in these disorders. And in the airway diseases, again, there would be air trapping, and pleural inflammation and pleural thickening and effusion is also seen in many of the inflammatory disorders, for example, in SLE, where you may see polyserositis. Now, the next step after an HRCT, which is considered to be relatively non-invasive investigation, although it does have side effects because of patient, bronchoscopy and BAL are investigations which are usually done after HRCT, but sometimes we may have to do it earlier. And a BAL can get us a sample from the lower respiratory tract, in which we can look for an infection, which could be an opportunistic infection. We may also analyze the BAL for autoimmune diseases, which we may find certain ratios of lymphocytes, which may be altered, for example, in HIV, where CD4, CD8 ratio is altered, and the opposite of that occurs in sarcoidosis. Alveolar hemorrhage can be picked up with the help of staining we do birth staining for hemosiderin-laden macrophages. And of course, neoplasms, which are also seen sometimes in children, there also, and they could be secondaries or they can be primary, and that can also be picked up, for example, certain forms of lymphomas. Then we have granulomatous polyangiitis or sarcoidosis. These have characteristic airway changes. For example, sometimes you may find changes in the upper airway in GPA, and you may find sarcoidosis also. There is a typical bronchoscopic appearance which may be seen in these patients. So after a bronchoscopy and BAL has been done in these patients, one would get some leads towards the diagnosis. And BAL, as you know, is known as the liquid biopsy of the lung, which can give us several type of cells which can be examined with special stains. They can be seen under the electron microscope, and certain antibody markering can also be done on that. But if still we are not able to make a diagnosis, and then one would have to go for a lung biopsy. But lung biopsies must be done before a clinical deterioration has occurred. That means usually before pulmonary hypertension has set in, because then it becomes a very high risk procedure. Video assisted thoracoscopic technique is preferred for doing lung biopsy in children. And this may actually rule out and rule in several type of disorders, which I think will be discussed now by Dr. Kabra. But sometimes you can pick up opportunistic infections also in the lung biopsy. Now, for the initial diagnostic approach for ILD, there is a possible diagnosis to exclude before evaluating a child for ILD, and those would be infection. And the diagnostic approach would be to do appropriate cultures, consider doing a BAL, and most of the times these days when the patients are admitted with chronic cough, they certainly undergo a bronchoscopy and BAL, and one looks for the relevant leads in these patients. Then cystic fibrosis can be ruled out by doing a sweat chloride. Immune deficiency workup is required, as I said. Complete blood counts, differentials, HIV should be ordered. Immunoglobulin levels would tell us whether there is any glutons present in the patient, if there's a hyper IgE syndrome, and sometimes it would also help us if there is any ABP, allergic bronchopulmonary aspergillosis. Then in recurrent aspirations, one would like to do swallow studies. One may even do 24 hours pH monitoring if you're looking for gastroesophageal reflux. And many of these swallowing disorders, we may have some aerodigestive problems. Then for congenital heart disease and for pulmonary hypertension, one would like to do an echo of these patients besides doing a clinical examination. Cardiac death is not usually done, but it may be done in selected cases when in a congenital heart disease, when one is looking for taking up these patients for surgery. Now, some of these tests have pros and cons, but I would say that most of the investigations can be done. They should be done, and things like flexible bronchoscopy and BAL should be done to help us whether there is whatever risk is there. We have to make our procedures safe for the patient. So flexible bronchoscopy helps us know about the anatomy. It will give us a specimen for microbiological cultures and cytological studies, but it may sometimes require deep sedation, anesthesia. Sometimes there may be a risk of hypoxia in these patients. A chest CT is something which is now almost done in every case, which characterizes the nature, extent, and distribution of the lesion. And sometimes it is quite diagnostic, and it's also a site for biopsy. Another investigation which is aided by a chest CT is FNA of the lung. And at our place, our aspiration cytology people are really good at getting FNA of the lung, and one can make a diagnosis of many disorders through that investigation. Although chest CT also requires anesthesia, and it would also lead to some bit of radiation, not some bit, but quite a bit of radiation exposure. So these days, people are actually going in for MRIs, and MRI lung is being standardized for diagnosis of several of these lung diseases. Then, of course, is genetic testing, which is in case of interstitial lung disease, there are several surfactant-related disorders which have specific gene defects, and they can be picked up by genetic testing, and one can go for normal sequencing, or one can go for next generation sequencing when we are looking for rare disorders. But of course, the relative cost is high, and we need people a bit trained in bioinformatics to interpret some of these findings. Then lung biopsy is the gold standard for diagnosis of interstitial lung disease. With actually, the open lung biopsy is considered to be the gold standard. Then there are certain clinical patterns of pulmonary manifestations in systemic inflammatory diseases. For example, in this child also, there was, I think, some positivity of ANA, and people were thinking of an inflammatory disorder, which could be due to rheumatological disorders. So I would just like to say that there are certain pulmonary disorders in which the presentation of pulmonary manifestations is a bit specific. For example, frequency at initial presentation of pulmonary disorders is much higher in systemic sclerosis, in sarcoidosis, and also in granulomatous polyangiitis. Frequency during disease course is there in certain diseases. Can I go to the previous one? Yeah. For example, in SLE, during the disease, sometime or the other, the patient would develop pulmonary manifestations, and the same thing would happen in systemic sclerosis and sarcoidosis and in GPA. Chest wall, etc., are involved only in juvenile dermatomyositis. Pleural disease is present mostly in SLE and JIA. Large airway disease is present in granulomatous polyangiitis. Bronchiectasis is actually present later when there is traction bronchiectasis in these patients. Acute pneumonitis is seen in SLE. ILD itself, it would occur in systemic sclerosis. Pulmonary granulomas are seen in sarcoidosis and in granulomatous polyangiitis, and vasculitis and diffuse alveolar hemorrhage is also seen in vasculitis. And pulmonary hypertension, of course, is seen in systemic sclerosis much earlier, and also in MCTD. And thrombosis is more commonly seen in ST. Next one, sir. So in the bar fluid analysis, where there is help in diagnosis, one may find intra-alveolar hemorrhage. There may be, in cases of alveolar proteinosis, the fluid which comes out is very characteristic, and it can actually tell us that pinkish white fluid, whether there is proteinosis which is present or not. In Langerhans cell histiocytosis, one can actually find these cells which are positive for histiocytosis cell markers. Then lipid storage disorders can be picked up with the help of lipid-laden macrophages. Same is true for aspirations. Alveolitis, when it is present, if there is alteration in the ratio of CD4 to CD8 counts, sarcoidosis and immune deficiency in the form of lymphoid interstitial pneumonia, which is seen in case of HIV, can be suspected. Eosinophilia would be seen in eosinophilic pneumonias, in eosinophilic granulomatous polyangiitis, the Schultz-Ross syndrome, and also in case of drug-induced kind of cases. Lymphocytes and neutrophilia are there in connective tissue disorders and also in gastroenterological diseases and drug-induced. Neutrophils would be seen mostly in infections and in acute inflammations. And if we do not find anything, then one would have to go for a lung biopsy.
Thank you so much, Dr. Meenu, for that excellent presentation. Now, what is the diagnosis now, Dr. Sushil Kabra?
Okay, sir. Next slide.
Yeah.
So before we say that what is the diagnosis, the summary of the child is 12-year-old girl with cough, exercise intolerance for 2 months, normal auscultatory findings, X-ray and CT scan showing a diffuse lung disease reticulonodular appearance with a raised total IgE. So this thing, say cough with exercise intolerance and a normal auscultatory finding, that suggests that it is probably an interstitial lung disease, because in all other conditions there will be some auscultation abnormality or some abnormality in the cough. So here one is that if IgE is raised, if there is a eosinophilia also with reticulonodular appearance and child is otherwise looking okay, so first possibility in our country may be tropical eosinophilia syndrome, and then you can do confirm it by doing a specific IgE against the filaria, and then the treatment is very clear. Otherwise, you will think of other interstitial lung disease, specifically hypersensitivity pneumonitis if there is a history of exposure to birds, as it is there in this patient. NSIP, that is a non-specific interstitial pneumonitis, which is a disease in adults but not in children, as if you are aware that we are very clear that it is an interstitial lung disease and there are 200 to 300 interstitial lung disease in children, while in adults there are only few. Either it is NSIP or it may be UIP or it may be fibrotic ILD. So NSIP generally you will think of if it is a say ground glass edginess and sparing of the subpleural region along with other things. But here in our patient, it is a diffuse lung disease with increased IgE. We'll think of whether it is a tropical eosinophilia or it may be hypersensitivity pneumonitis. And then the problem in say lung biopsy, as Dr. Meenu suggested that lung biopsy is the gold standard. So what are the problems and challenges? So next slide, please. So challenges in pediatric lung biopsy is difficulty in transbronchial biopsy due to small airways. As you can do bronchoscopy with 3.8 millimeter or 4.2 millimeter bronchoscope, and the biopsy tissue will be just a 1.2 or 2 millimeter. So it is very difficult to interpret. So we need a expert pathologist who is interested in interpreting it. And there is a reluctance on part of surgeons because there is a high morbidity and they have an impression that biopsy does not add to the diagnosis. And even if diagnosis is made, no specific treatment is there. Anyway, you will be giving steroids. So these are the problems, but what are the indications if you are suspecting it to be interstitial lung disease or malignancies? And now I'll tell you what are the various methods. Next slide. So one is you can do a transbronchial biopsy in which you are giving a conscious sedation, you are passing your bronchoscope and you are passing your biopsy forceps and you are picking up the tissue, picking up the mucosa. And that would be helpful in hypersensitivity because there is exposure to the airway, some abnormal allergens. So you will be able to find some abnormality in the mucosa, sometimes in sarcoidosis and in post-transplant patient. If the other thing is transthoracic blindly, you can do it, but it is associated with pneumothorax. That's why nowadays it is not being done. Either it will be done either CT guided or ultrasound guided. So mini thoracotomy, which is decided by the CT scan, and it is an invasive procedure, but useful in interstitial lung disease and malignancy. Another thing, as Meenu suggested, video assisted thoracoscopy, which is invasive, but it requires expertise and better yield and less morbidity and useful in all the conditions. The new one is cryobiopsy, in which what you do is you pass your bronchoscope, you pass through the suction channel, you pass your cryoprobe, and then you cold it, and then a small tissue around it is taken out, and that has a good diagnostic workup for interstitial lung disease. Next.
This was the lung biopsy done 17/5/17. Wedge biopsy on the middle lobe of the right lung was taken. Peribronchial bronchular infiltrates composed of lymphocytes, histiocytes, plasma cells, and lymphoid aggregates was noted. There was no definite granuloma seen. FT stain, no acid bacilli, PAS and GMS stains, no fungal elements seen. So the impression was non-specific interstitial pneumonia pattern. The differentials of hypersensitive pneumonitis, lung involvement due to connective tissue disorders, and idiopathic. So in the review of history, we elicited that there was significant exposure to pigeon droppings in the apartment that they were staying. So a diagnosis finally was made of a diffuse lung disease, probably hypersensitive pneumonitis, probably by IBN antigen. Connective tissue disorder was also kept in mind. She was started, ITT had been stopped. She was started on oral steroids at 2 milligram per kilogram and cotrimox for prophylaxis. Low dose inhaled corticosteroids was started. Avoidance of pigeon droppings and exposure was advised, and the patient was sent back to the BI. The 1 month follow-up, in India was this was the spirometry. Could Dr. Somabalan explain the spirometry changes? Dr.
Yeah. As I said earlier, first when we are doing the spirometry, probably the reference value will come in handy. And the subsequent thing, one is for diagnosis. Most of the time, it will give a suggestive appearance. Here, it might say it is a restrictive or an obstructive disease, but it will not tell you whether it is an asthma or if it is interstitial lung disease of a particular cause. So that we have to correlate only clinically. So here we have done the previous spirometry, and there it was suggestive of restrictive pattern. After treatment, the child, of course, is feeling better. And we also want to have something documented and objective. So we are repeating a spirometry here, though I'm not able to see the values clearly.
FVC EX was 36 initially and was 60 on follow-up.
So it is 60 on follow-up, and even if you see the loops, it is considerably a bigger loop compared to the top, which is lower, smaller, which is like peanut size. The next one has become something like a small gooseberry size. So it has increased in size. So that itself tells you that it is better, and of course it has been substantiated by your values, which has also increased compared to before. So sequentially and periodically, even on follow-up, the child has to be followed on these things. Even all interstitial lung disease and autoimmune diseases, we tend to do them serially every 6 months to 1 year, even if they are asymptomatic, just to see how the lung function goes by. That is important.
Thank you so much. So after follow-up for 2 years, is an oral steroids were tapered and stopped after 2 months. ICS was given for 1 year. On tele-follow-up, the patient is asymptomatic and doing extremely well. So she's sort of got over her problem with the course of steroids. What is the Indian series of ILD, your experience, Dr. Kabra? Sushil? Dr. Sushil? Yeah.
Yeah. So there is a limited information and limited to some case reports, no community-based data to say that what is the magnitude of problem. And from North India, from our center, there were 90 children who were reported. And from South India, there were 9 infants which were reported for ILD. There were the median duration of symptoms was 12 months, suggesting that, and the interquartile is 5 to 36 months, suggesting that there is a significant delay in suspecting and diagnosis. So there is very important aspect is that if a child is having a chronic cough, minimal auscultatory finding and breathlessness on exertion or some evidence of hypoxia, think of interstitial lung disease. There are around 300 types of interstitial lung disease in children. Some of them are reversible. So this is almost 2 decades ago. This was a retrospective study in which 90 children with ILD were analyzed, and majority were idiopathic pulmonary hemosiderosis, Langerhans and histiocytosis, post-infectious like tuberculosis or measles, hypersensitivity pneumonitis, Stevens-Johnson syndrome associated, and then there were a few more like SLE associated, pulmonary alveolar proteinosis, pulmonary microlithiasis, and radiation pneumonitis, and unclassified ILD. So it is important to understand that we have to have a high index of suspicion. And the clinical manifestations are very varied, and they may be asymptomatic with classical manifestations, insidious onset like dyspnea, slowly increasing tachypnea, cough, and exercise intolerance, as it was there in cough along with some degree of tachypnea. Fever is uncommon unless it is secondary to infections and hypersensitivity pneumonitis. Failure to thrive, weight loss because of the exertional dyspnea and increased oxygen requirement. Chest pain, hemoptysis are less common. Clubbing, cyanosis, intercostal retraction, dry velcro crackles, that depends on the severity of disease. And wheezing may be present in 50% as it was present in our cases. Next slide. And as you can see, cough, dyspnea, crepitations, pallor, clubbing, hemoptysis, and wheezing, these were the clinical manifestations in our patient. So it is important. I thought that I should share it with you. That's why I requested Dr. Jason to include these slides. We came across some infants.
Dal aspiration.
We came across some infants who developed sudden onset of respiratory difficulty after forceful feeding of dal, or you can say sambar. Children continue to have a respiratory difficulty weeks following auscultatory acute event, and X-ray and CT scan suggested massive consolidation in the parahilar region, as you can see here in the first X-ray. And On CT scan, there were granulomatous granularity along with ground glass opacity. And our belief was that this is secondary to DAL aspiration. Next. And how we confirmed. After ruling out infections by appropriate investigation, including these bronchoscopies, X-rays, and other things, we treated them with steroids. And there was a dramatic improvement. Condition fits very well with the hypersensitivity pneumonitis. And we explored the possibility of documenting IgG against lentil, and we could document it. And you can just show the previous slide, Dr. Jason. You can see this is after 2 weeks of steroids. So there is a massive consolidation in the parahilar region, which is now clearing within 2 weeks after giving steroids. Next. And this is we could document that there, all the children had a very high IgG against lentil, and which we developed in our institution. So this is just to say that for hypersensitivity pneumonitis, specifically say this bird related pigeon exposure sensitivity. So people want to avoid doing a biopsy. So how we can do that? Do a take a good history, get a X-ray film and CT scan. If it is suggestive of hypersensitivity, go for a bronchial lavage. If CD4 CD8 ratio is less than 1, then it suggests. And if you can have a IgG against the avian allergen antigen, then it is confirmed. Then there is no, it will have a sensitivity of almost 84-85% and specificity of 94%. So you can avoid biopsy. Thank you very much.
How many cases have you seen so far of lentil?
Lentil, we may be seeing almost 1 to 2 every 2 months.
Oh, that frequent.
Yeah, it's very common. Like if you see child rearing practices, dal is the common food, dal ka pani, and then the mother will hold the children hand and food, and then they'll put it in the mouth, and then it goes in the respiratory passage. Sudden onset of respiratory difficulty, and they continue to get all sorts of treatment, tons of antibiotic, and including anti-tubercular drug.
Oh. Thank you so much, Dr. Kabra. And Dr. Minu Singh, now how do you follow up these children with ILD? Unmute, please. Unmute. Please unmute.
Yeah. So I just wanted to share with you an experience of a child which we got from Bihar recently. And this child had a interstitial lung disease, had very low effort tolerance, and there were significant interstitial opacities on CT. And this child, when we went into the details of history, they were actually breeding pigeons. In fact, there was a small little bird house with them in which these children used to play, and there were a lot of pigeons around. And we suspected this pigeon hypersensitivity. This child also had eosinophilia as well as raised IgE, and then specific IgE to this pigeon feather was done in this patient, which came to be positive. And this child also did well on one is we told them to let all the pigeons fly and not keep them in the house. And second thing was that the child was given steroids for some time. And this child also has been doing well, although he had more lung damage, I think. So he has a residual chronic lung problem, which is existing in this patient. So, this is a disease which is common, and because of pigeon droppings, we know that interstitial lung disease can be there. And to follow up these children, for example, the child which we just discussed, the history was because this was a secondary cause. The patient was allergic, and once the stimulus was removed, this child improved and responded to steroids. So probably child did not need a very long follow-up. But otherwise, also we need evaluation at 1, 2, 3, and 6 months, and then at 1 year, depending upon what kind of disease is there. The monitoring tools are, of course, clinical symptoms. We look at the symptoms as well as objectively look at respiratory rate, heart rate, weight, oxygen saturation at room air, and evidence of pulmonary hypertension, whether or not that is developing, or sometimes it does reverse also with treatment. And In radiological investigations, X-ray chest is advised at 6 or 12 months if required. Pulmonary function tests can be done on a yearly basis if the child can perform them. And diffusion capacity also should be done yearly because that is the site where interstitial lung disease is actually residing. So diffusion, which is the alveolo-capillary membrane, and diffusion capacity is certainly helpful in finding out. And some people recommend it for the early diagnosis also in some patients. Next, that's all.
Thank you so much. That was an excellent case presentation. I'll stop sharing my slides and this pigeon, we have something called parva. I mean, there are boys who fly these pigeons and they they have these pigeons as their pets, and many of these children have this wheeze, wheezing. Now there is a question like, can you please explain some ideas about how to identify reticular nodular shadows on the X-ray, Dr. Kabra?
See, as Dr. Meenu has very clearly defined that miliary shadows would be 2 to 3 millimeter, 2 millimeter or less than that. If there are 2 to 4 millimeter or more than 4 millimeter, then it becomes a nodule. And then if you are finding multiple shadows, along with that, there is interstitial shadows that will give appearance of a reticulonodular appearance.
Okay, Dr.
So more than a miliary shadow, and less than a coincept shadow, that is around 4 millimeter would be the nodules.
Dr. Shiba asks, what is the role of rising industrial and environmental toxins in the causation of ILD in children? House milk allergy and ILD?
What is the role of?
Industrial and environmental toxins in the causation of ILD in children? Cause milk and allergy, does it cause ILD?
Yeah. As I said, in children, there are more than 300 types of ILD, and environmental factors are the commonest cause of hypersensitivity pneumonitis. Commonly described are hypersensitivity to molds and different types of molds, and hypersensitivity to these pigeons and other birds. And they are increasing in countries where there are increasing molds, and that's why the first investigation for suspected ILD. So ILD would be suspected on clinical grounds, say cough along with the breathlessness and hypoxia. So in that case, even the workup includes, one is doing the serology in the patient, along with that taking samples from the house for culture of these molds and other things. Second thing, as she rightly pointed out, whether it can be part of say cow milk protein allergy or intolerance. That is slightly different condition that doesn't come under the purview of interstitial lung disease, but they are commonly seen with the chronic respiratory diseases. It starts during infancy and then subsequently it may go off, and they are entirely different from that of asthma.
If I may add a little bit to the environmental exposure and toxins causing disease, we have seen patients of pneumoconiosis related to, there was a child from Bihar who used to reside close to the coal mines, and this child actually had anthracosis. Then there is silicosis occurs in these patients of children who are there accompanying their mothers who are working at the construction sites. And these patients also get something like interstitial lung disease, and they have more of pneumoconiosis. We had a very interesting case today in our CPC in which they had described lung lesions because of the caixylate resin which is given to the children when they are being treated for hyperkalemia in some of these hospitalized patients who have chronic renal disease. So things like this can also lead to lung problems and things like interstitial lung disease. There was about cow's milk protein allergy. Sometimes it does lead to Heiner syndrome, and in that situation, when there can be pulmonary bleed also in these patients because they do get vasculitis like features, and that sometimes gets kind of diagnosed as an interstitial lung disease in these patients. But that's actually different, as Dr. Kabra already pointed out.
Dr.
And
Keith,
about,
yeah,
something about FNA, which is written here. It is not
Yeah.
done transbronchially, it is done transthoracic. So it is usually done after a CT has been done, and the region which is most affected, that is kind of aspirated with the help of a needle. That is for the FNA of the lung. The ones which are done transbronchially, they are done through transbronchial ultrasound, like EBUS, and that is mostly done for the lymph nodes, which are there either around the bronchus or in the carinal region. That is something, that is the aspiration which is done, which is not so much done in case of ILD. That is done more in diseases where there are lymph node enlargements. In sarcoidosis, of course, transbronchial lung biopsy is helpful in older children and in adults. And when they have lymph nodes which are around the uh, airway, then one can reach them through EBUS. Because if these children are a little older and we have those kind of instruments which can pass through, those airways. So,
Dr. Somu, do you get instant lung disease in South so much?
Yeah, we do get, but the thing is, most of the time they are being treated like asthma, or they think that giving an inhaler treats all problems, or an ATT. These two happen. So as a clinician, not as a pulmonologist, as a clinician, when to suspect ILD becomes a question. Meaning clinically, any persisting problem more than 4 weeks, 4 criteria: symptoms, sign, air exchange abnormality, or radiology. Symptoms can be cough or breathlessness, or any respiratory thing other than the URI which is persisting more than 4 weeks. Or signs, you can have increased work of breathing, crackles, or wheeze, or there can be nothing also. And third one is air exchange abnormality, hypoxia. Hypoxia, there is a question on pulse oximetry also. Other than the COVID, the normal saturation doesn't mean the child is having a normal lung function. So in a suspected case, in a background of persisting cough or signs and symptoms, always make them to walk or run or make them to exert. After which, if there is going to be a fall in saturation, that itself tells you there is a suspicion of interstitial lung disease or a significant amount of lung involvement is there. And fourth thing is radiological abnormality, chest X-ray or CT evidence of interstitial lung disease. Chest X-ray need not manifest in the early instance. ILD and early bronchiectasis are only thing which are being picked up by CT rather than by chest X-ray. So I'm not telling you do the CT for everybody. So when a background of ILD, when you suspect an ILD, when the chest X-ray is normal, you can go ahead and do a CT just to see if there is suggestive evidence of ILD. So signs, symptoms, air exchange abnormality, and radiology. Of the 4, if any of these 3 things are there, and if the history is more than 1 month, probably think in terms of ILD also.
Ketan Kumar has asked whether it's okay to make a diagnosis of HP without a biopsy.
Yeah, for a pigeon-associated hypersensitivity pneumonitis, Dr. Ketan, you know that one is that you'll suspect on the basis of history, physical examination, chest CT, GGO, along with say some nodularity. If you can document there is an increased IgG against these allergens, antigens against the pigeon antigen. And then the last thing is if you can do a bronchoscopy and document that there is a CD4, CD reversal less than 1, then you are reasonably sure that it is a pigeon-associated interstitial lung disease. Otherwise, you can go for a biopsy, and all of us are worried about the biopsy because of associated morbidity and mortality. So you can reasonably make a diagnosis that yes, it may be a pigeon-associated this thing with these 3 things: clinical features in radiology, serum IgG against the specific allergen, and then the third thing is broncholar lavage, CD4, CD8 pressure.
Dr. Sobodh has asked, is there other birds and animals can cause ILD other than pigeons?
yeah, I think parakeets, like parrots, can there, because most of these are the birds which are kept inside the houses, and they can lead to psittacosis, and they can have something like this disease. In pigeons, of course, it is not just the feather; it is actually the pigeon droppings which are which have that proteinaceous substance which initiates this allergy as well as interstitial lung disease. So I think all kind of birds which are kept inside the houses, if you have more exposure, there is every possibility that you may develop some kind of allergy to the bird dander and feathers.
Ketan Kumar is again and again asking with the granulomas, can you make a diagnosis?
Yeah, there is no need for granuloma
Yeah.
to be 100% in all the ILDs, Dr. Ketan. It may be even without granuloma.
And Dr. Rajagopalan finally asked whether what is the incidence of sarcoidosis in pediatrics?
We have seen, in last 10 years or so, I think there would be not more than 3 or 4 cases. So it's not very common in children, although there were some series from Calcutta. Dr. Deeman Ganguly actually had reported more sarcoidosis even in young children. But Dr. Kabra, I think, also would agree that
we have reported, Dr. Menu, we have reported in IJP 18 patients 2 years ago only. So it is rare, but at a referral center, you may find it.
Yeah.
So we have reported a detailed description of all these sarcoidosis from AIMS 2 years ago. So it is not so unusual, but but it should be considered specifically if a child is less than 4 years, then there will be arthritis hepatosplenomegaly along with lymphadenopathy. If it is an older patients, then it would be predominantly intrathoracic lymph node along with interstitial lung disease.
Thank you so much. There's a lot more questions will go on coming. So we're going to finish the quiz, start the quiz anyway. I think Pramod can just tell the PGs how the quiz is answered.
So basically, you have to answer the question in the chat box with question number as numerical and answer as alphabet, and the first correct response will be considered. So kindly put so you have to put your answer as 1 and then your correct response.
Okay. A silent chest with infiltrates should arouse suspicion of all of the following except alveolar proteinosis, bronchopulmonary dysplasia, pneumocystis jovare infection, interstitial pneumonitis, or tumors. No answers? Okay, I'm going to the next one. Cardiovascular causes of wheezing include right atrial enlargement, left atrial enlargement, right ventricular enlargement, left ventricular enlargement, and coactivation of aorta. Third is bronchiolitis obliterans is a rare chronic obstructive lung disease of the bronchioles and smaller airways. And the best means of establishing a diagnosis is chest radiographs, PFTs, ventilation perfusion scans, CT chest, open lung biopsy. Okay, next. All lung volumes can be measured by spirometry except tidal volume, inspirated reserve volume, expirated reserve volume, residual volume. Next. Pulmonary function tests labeled as normal when the results decline over time, fall outside the 95% confidence level for age, height, and sex, fall outside the 95% confidence level for age, weight, and height, fall outside the 99th percentile for age and sex.
Hello? Sorry.
The definition of obstruction on PFTs is best defined by FEV1 by FVC, that is less than 75 to 75th percentile of predicted, and FVC, that is less than 75% of predicted, a maximal intravenous flow that is less than 70 to 75% of predicted, a total lung capacity that is less than 70 to 75% of predicted. Persistent cough may need to be sought beyond the lungs because cough receptors also reside in the following regions except pharynx, paranasal sinuses, stomach, nose, and external auditory canal. A 15-year-old with cystic fibrosis presents to the emergency room with fever, worsening dyspnea. A chest X-ray shows marked hyperinflation of the lobe and lobar consolidation of the right middle lobe. Which is the following statements regarding cystic fibrosis is true? Finding a bronchiectasis is inconsistent with a diagnosis of cystic fibrosis. Cystic fibrosis is an autosomal recessive condition inherited through genetic expression of chromosome number 5. Exacerbation of illness due to serious infection is the most commonly caused by gram-positive organisms. Maintenance therapy of cystic fibrosis includes bronchodilators and airway clearance and DNAs. The underlying defect of cystic fibrosis is in sodium and potassium transport channels in the lung and other organs. HRCT is sufficient to make a definite diagnosis in which of the following conditions: neuroendocrine hyperplasia of infancy, pulmonary interstitial glycogenosis, pulmonary alveolar proteinosis, and idiopathic pulmonary fibrosis. Which condition was previously called bronchiolitis obliterans organizing pneumonia or BOOP? Crazy paving pattern on HRCT is seen in idiopathic pulmonary hemosiderosis, surfactant deficiency, pulmonary alveolar microlithiasis, pulmonary alveolar proteinosis. What does the differential diagnosis of crazy paving pattern of HRCT on include? Acute respiratory distress syndrome or ARDS, radiation or drug-induced pneumonitis, pulmonary edema, bronchiolitis obliterans organizing pneumonia or BOOP, all of the above. And the last question is, which drug is not known to cause drug-induced interstitial lung disease? Tetracyclines, amiodarone, methotrexate, and nitrofurantoin. Thank you so much, children, for that participation. I'll now have our experts to go through the answers while Dr. Pramod and Dr. Ranjit will check out the answers, the winners. So I think the panelists be ready for answering these questions. The The first was silent chest with infiltrates would arouse the suspicion of all of the following except Dr. Sushil.
Okay. So it would be this thing, bronchopulmonary dysplasia, because if you see alveolar proteinosis, pneumocystis jirovecii infection, interstitial pneumonitis, and tumors, they may cause obstruction and they may cause a filling of airways as well as alveoli. So there may not be much of a air movement. While in bronchopulmonary dysplasia, it involves the airways along with the alveoli, but they are open and then they'll produce some sound while while the child is taking breath sounds.
Thank you so much. Cardiovascular causes of wheezing include Dr. Minu.
Yes, we know that cardiac defects that result in significant enlargement of the pulmonary artery can cause bronchial narrowing and wheezing. And the common sites of airway narrowing would be something like left lateral trachea, left mainstem bronchus, left upper lobe bronchus, or right bronchus intermedius sometimes. So the left mainstem bronchus is susceptible to compression with the cardiomegaly, especially with the left atrial enlargement. So left atrial enlargement actually is the answer for this question, which would lead to, sometimes it may even lead to noisy breathing or something along with the wheezing. There may also be stridor present in these patients. So it is actually, that is the cause in these patients.
Thank you so much.
Yeah.
Bronchiolitis obliterans, the best means of diagnosis is Dr. Minu?
Again, open lung biopsy is the the way these patients would be diagnosed. Then chest X-rays are usually normal in bronchiolitis obliterans, but they may show hyperinflation. PFTs may decline slowly in some type of bronchiolitis obliterans, requiring repeat medical testing and follow-up. As we know, in lung transplant patients, when they develop chronic rejection, they have bronchiolitis obliterans, and that is picked up by PFTs. A surgical biopsy and histopathology, however, remains the gold standard approach to confirm the diagnosis. So, and with that, three main bronchiolitis obliterans entities are distinguished. One is post-infectious, another one is post-lung transplantation, and the third one is after bone marrow transplantation or after hematopoietic stem cell transplantation.
Thank you, Dr. Minu. Dr. Somu, the lung volumes measured by spirometry?
Everything can be measured. The residual volume will not be measured. So as I said, deep inspiration and deep expiration, the residual volume doesn't come to play. That remains standard. So that is not measured. When the residual volume is not measured, the total lung capacity cannot be measured.
Next, Dr. Somu, the pulmonary function test labeled abnormal when the results are?
Of the choices, it will be the second, that is the fall outside the 95th centile confidence level for age, height, and sex. So that is the thing. There can be exceptions to the rule. So it has to be correlated clinically, and sequentially it has to be monitored also. Most of the time in the first instance, when you happen to see that, and if they are falling outside that value, it becomes abnormal.
What about definition of obstruction in PFTs? Obstructive disease, best defined by?
Best defined by FEV1 bar, the ratio, if it is less than 70 to 75%, but the values slightly keep changing. In the older, younger children, they say the ratio can be even as high as more than 85% is considered to be normal, whereas in younger children, it's 85, and older children, they say 70 to 80% is also normal. More than 70 to 80% is also normal. That is how the lung evolves and the capacity evolves over time. So that one has to be added in mind. Most of the time, around 80, keep it as a cutoff.
Persistent cough may need to be sought beyond the lungs, Dr. Minu.
Yeah. And so we have to see where all cough receptors are present. So which is the situation in which this would not occur, and that is actually the nose. because cough receptors reside in pharynx, paranasal sinuses, stomach, and external auditory canals. So this choice number D is the right one because they may not be present in the nose. Otherwise, the source of persistent cough may need to be sought beyond the lungs.
Thank you. Now, this is Dr. I think Dr. Cabra. Cystic fibrosis, so which of the following statements regarding it is true, is the question. Dr. Cabra, Dr. Sushil?
Sorry.
Yeah.
Sorry, I did not. Okay. So this 15-year-old girl with cystic fibrosis present to the emergency room with fever and worsening dyspnea. X-ray shows a marked hyperinflation and lobar consolidation in the right middle lobe. Which of the following statement regarding cystic fibrosis is true? The first is finding of bronchiectasis is inconsistent with the diagnosis of cystic fibrosis because there are multiple causes of non-CF bronchiectasis also. So it is not true. Cystic fibrosis is an autosomal recessive condition inherited through the gene expression on chromosome number 5. So it is autosomal recessively inherited, but gene chromosome 7. So it is also not true. Exacerbation of the illness due to serious infection is most often caused by gram-positive organism. So this is generally, initially it would be gram-positive like Staph pneumoniae, Staphylococcus, and once you give this thing antimicrobial, then they select out this Pseudomonas. So generally it would be Pseudomonas which is responsible for severe exacerbation. Maintenance therapy of cystic fibrosis include bronchodilators, airway clearance, and DNS. So this is the treatment, like your main aim is to loosen the thick viscid secretion by doing a good chest physiotherapy. And if available, you can use DNS. Otherwise, you can use hypertonic saline. And if that is also not available or not able to use, then in exceptional circumstances, you can use N-acetylcysteine. So this seems to be correct. The underlying defect of the cystic fibrosis is sodium and potassium transport channels in the lung and other organs. So it is not the sodium and potassium, it is the chloride channel. So D is the answer.
Thank you so much, Dr. Cabra. HRCT is sufficient to make a definitive diagnosis in which of the following conditions, Dr. Cabra?
So it would be this thing, knee-high neuroendocrine hyperplasia of the infancy. So what happens is that it has a very typical characteristic finding on CT scan in form of a GGO, which is overlapping the heart borders, say involving the lingula and of the middle lobe, and that is very characteristic. So that's why if it is there with a clinical background, then there is no need for going for any further investigation.
This again to you. Which condition was previously called bronchiolitis obliterans? BOOP.
Bronchiolitis obliterans with organizing pneumonia. That was a cryptogenic organizing pneumonia, because non-specific interstitial pneumonia is when there is a peribronchial problem and there is a distinct bronchiectasis. Desquamative interstitial pneumonia, it would be something like when there is a desquamation of the alveolar and peripheral bronchiolar mucosa. So it will produce more of a consolidation. And lymphocytic interstitial pneumonitis is proliferation of the lymphatic tissue. So this would be cryptogenic organizing pneumonia.
Thank you. Creasy paving on the HRCT, Dr. Minu, is seen in Dr. Minu Singh. Dr. Minu?
Yes, yes. Yeah. So it's seen in surfactant deficiency. And this is the answer for this is pulmonary alveolar proteinosis. I mean, it is actually seen in this kind of surfactant disorder. And as you can see here, the anterior part of both the lung fields is showing some typical crazy pavement kind of changes, like you see it here. And with central ground glassing and peripheral interlobular septal thickening. And in the periphery, there is a interlobular septal thickening, as you can see over here. And there is increased density secondary to gravitational accumulation of lipoproteinaceous fluid. So it's seen in the lower part of the lung more prominently because this this fluid actually it kind of gravitates in the lower part of the lungs. So the answer is D.
Thank you. And what is the differential diagnosis for crazy paving pattern?
So it is actually almost all of them, because the differential diagnosis for acute respiratory distress syndrome or radiation lung pneumonitis, pulmonary edema, bronchiolitis obliterans organizing pneumonia, which was just discussed, which is cryptogenic interstitial lung disease. So all of them are actually can be in the differential diagnosis of crazy paving.
Last question, Dr. Sushil. What is the drug which does not cause drug-induced ILD?
So it would be tetracycline, because amiodarone, methotrexate, and nitrofurantoin, they are well known to cause this interstitial fibrosis.
How do you? Which is the most common? You said methotrexate. People on
Generally, now nitrofurantoin is no more being used commonly for UTI prophylaxis. Amiodarone is also not being commonly used. So it is commonly methotrexate which is being used for rheumatological disorder, because that is now the first drug which is used, first choice of a drug for juvenile idiopathic arthritis as well as sarcoidosis and other conditions. So it is being used, and now people feel that we should identify, because it may be causing a slow fibrosis, and there is not much of a symptom. So it should be identified early by high index of suspicion, and that's why people suggest that you do clinical examination, but that may not pick it up, but you can do a DLCO. And problem in DLCO for children is that the equipment which is available for doing this thing is for adults, in which you have to hold the breath for 8 to 12 seconds, which is not possible in children. So now there are equipment in which you can do it with the tidal breathing. So that should be done routinely on those who are on slightly higher doses of methotrexate.
how frequently do you do that? How frequently
It
do
may
you?
be every 3 to 6 months. When you are seeing the patient, 6 months, once 6 months can be done. If it is more than 15 milligram per meter square per week.
Thank you all so much. It was an excellent session. I hope all of them enjoyed the case, and now we'll have Dr. Pramod to announce the winner.
It was a fantastic session, and I congratulate Dr. Ketan Kumar from PJ Chandigarh, who's doing his DM in pediatric rheumatology and
Pulmonology.
Terminology.
He is student of Dr. Meenu.
Okay.
He's doing his
So he
DM
is
in
our
pediatric pulmonology.
ex-student, but he is now working with Dr. Meenu and getting a very good training.
so
Very good. See, the winners have always been game students. That's a problem. All the winners in this quiz and our potpourri has been game. I told you yesterday, it's all game students are winning. But that's fantastic. Dr. Ketan
Kumar,
PJ Chandigarh.
You can
Congratulations,
say
Dr. Ketan.
Yeah, congratulations.
Yeah, you will be sent your certificate by speed post soon. Thank you so much. If there are, I invite Dr. Pramod to say the vote of thanks.
So my secretary is currently very busy with the COVID transport system, and he is in charge of the system. The IMA program here. So I thank everybody who has come here and made a wonderful presentation, especially Professor Sushil Kabra, Professor Meenu Singh, Dr. Somu, Dr. Jason, and everybody else who has made it a very grand success. Thank you all, and good night.
Thank you.
Thank you so much. Thank you so much, Dr. Kabra. Thank you, Dr.
Thank you very much. I
Thank you.
enjoyed it.
Thank you, Dr. Jason.
It was
It was
lovely. Thank you
great
so
fun.
much. We'll
Thank